All right. This is our week 7 patient care and pharmacology live lecture. And we are going to discuss, first off, mobile radiography. So when we say mobile radiography, what we mean is the part of radiography that we perform the images at the patient's bedside. So in order to do this, we have to have special equipment. So we have special mobile unit like our portable x-ray machines. We also have C-arms. We have uh the C-arm can perform fluoro. This could be used in the surgery setting or at the bedside. And then also currently something that's more current and new to the field are portable CT scanners. So all of those would be classified as mobile radiography. So some of the places that we would utilize mobile radiography would be in our post anesthesia care unit. So that's going to be of the what we call our PAC unit. So PACU. This is referred to as the recovery room. Then we'll also use mobile radiography in the ER, in the neonatal intensive care and newborn nursery. That's the NICU. The NICU is a unit that special unit that cares for babies who are premature, low birth weight, or have health issues. And then also in our ICUs and coronary care units. So ICU and CCU are used to care for some of our more critical patients, those who are very ill, who require frequent, if not constant, monitoring. So a couple of things that we do or procedures that we assist with at the bedside using mobile radiography include nasogastric or nasoenteric tubes. So we're placing these at the bedside. So this is a nasogastric tube is referred to as an NG tube. And this is a tube that passes from the nose to the stomach. And then we have nasoenteric tube. That's a tube that passes from the nose to the duodenum. Then we also perform closed chest drainage. A closed chest drainage is to remove fluid or air that has accumulated in the pleural space. We use it to place specialty catheters, such as CV lines, peripheral lines, and PICC lines. And then we also use mobile radiography to help place pacemakers, which our pacemakers are going to be those electromechanical devices that regulate the heart by providing low levels of electrical stimulation in the heart muscle. You usually see pacemakers in the cath lab. In the cath lab, we do have technologists that work there as well, and they do a lot of pacemaker procedures. So you'll usually see the pacemakers being kind of done with mobile radiography in the cath lab. All right. If you have to perform a mobile radiography exam, say you're in an inpatient setting, in a hospital setting, and you have to do a portable x-ray. There's a couple things, general guidelines we should follow or think about when we're going to the patient. That's a little bit different than the patient coming up. We want to first call the nursing station to make sure that the patient um is okay. Is this patient, how well can they move? Are they alert? Do they know what's going on? Have you all let them know that they're going to get this test done? So you want to ask the nurse about the patient's condition. Then you want to make sure you confirm the order in the patient's chart. When you get to the patient's room, you want to greet the patient, kind of explain the procedure, what's going to happen. You want to verify your patient, make sure you have the right patient. So check their patient ID band, their birth date on the wristband, and then start to inspect and prepare the room So you know how to, you need to position your equipment in room, I guess, to just make sure you have enough room. Sometimes those ICU rooms can be a little tight, so you have to do a little maneuvering. You may have to move or angle the bed, and you have to do kind of rearrange some things to kind of get the machine in, depending on whether you're using kind of like a portable or a C-arm. So we're gonna watch a short video about mobile radiography. And this is gonna talk about that portable CT scanner that I was telling you guys about. Let me get that pulled up and we'll take a look at it. Just a short video.
What is IgA nephropathy and how do you know if you have it? IgA nephropathy, or IgAN, is a disease that causes
Stroke is a leading cause of death and the leading cause of disability.
With stroke care, every minute counts.
It's estimated that we lose about 2 million brain cells a minute.
I remember being really sleepy, and I remember one time kind of stumbling around.
You want to get treatment as fast as possible.
Hold on, guys, because it wasn't sharing the screen. Hold on. Let's try this again.
Cleveland Clinic's mobile stroke treatment unit is an emergency room on wheels. When an EMS squad gets dispatched for a potential stroke patient, we get dispatched at the same time. If it does turn out that the patient is experiencing stroke-like symptoms, care will be handed over to us. This unit has all the tools available. The unique part of our truck is having the CT scanner on board. We can determine what type of stroke they are having, whether it be an ischemic stroke, which is when there is a clot blocking the blood flow to the brain, or a hemorrhagic stroke, which is when the artery ruptures. Could you tell me where you are? Our critical care nurse and paramedic will assess the patient, hook them up to our cardiac monitor, insert IVs, as well as draw the laboratory samples. Then we will bring in a physician virtually to examine the patient.
Hey, Dr. Uchino, this is a 61-year-old female. Stood up. She started feeling like giving away her right leg.
We can get into the vehicle via the telemedicine and see the patient and make their assessments.
How are you doing? Can you talk to us?
If there's any type of therapy to be administered, we will do it right there on scene.
TPA is infusing.
We have good evidence now for the use of intravenous TPA, which is the clot buster medication. And we can use that medication up to 4.5 hours after the onset of a stroke.
We're actually seeing that we're saving 90 minutes of time by bringing everything to the patient.
This unit was first trialed in Germany in a couple of centers, but we're first in the United States to be rolling this type of program out. We were able to implement different aspects of what they had done, but also innovate and bring in new elements that would be useful in our healthcare system.
One of the unique things that kind of separates us from the German experience is that we have the ability not only to treat the ischemic stroke, but also to treat the hemorrhagic stroke as well. We are able to administer therapy right on scene much sooner than if they were to come into a hospital.
In the United States and around the world, people are looking at this type of model to see whether they can implement it in their own setting. Really does take an organization like Cleveland Clinic to bring together the resources and take the initiative to do this kind of project.
We're here because we want to provide this type of care out to the community that much faster.
I could be not talking to you at all. I could really be having crazy those residual effects, or I could be even not even alive. I thought that was it. That this was the day that I was going to lose my grandmother. She has a second chance at life thanks to the people on the stroke unit.
It's exciting to be able to actually see that you're making a difference in a patient's life.
Okay. So mobile stroke unit, there are around 20 mobile stroke units in the US in different states. I know they have several in Texas. And fun fact, the first mobile stroke unit was actually developed in 2014 at the University of Texas Health Sciences at Houston. So that just gives you another outlook on how, number one, how helpful or how um vital imaging plays in the healthcare system. That's another avenue of work for you all. You can work in a hospital setting, you can work in an outpatient clinic. This is another avenue, to utilize the skills you're gonna learn. So not only working in CT or MRI, mammography, ultrasound, you have an avenue also of working in the mobile stroke unit. So kind of just gives you a outlook of the different avenues that you can take, different things that you can do in radiography. I like to tell people that, you you don't necessarily get bored working in radiology, because if you get tired of doing one modality, you can always go and learn a different modality. So that's something that's neat, I think, about our field, is that, if you learn one, you can always go learn another. You can work in both of them, of both of those areas. So, that makes you a more marketable technologist when you get out in the field, because a lot of times people will want technologists who can do multi or several different modalities. So they call that a multimodality tech. So they like to see, and you get paid a little bit more too when you're a multimodality tech. So just some insight and a little bit of more detail on a couple different technologies that we're a part of in the healthcare field. So now we're gonna veer off into the surgery part of imaging. So anytime we go into the surgery side of things, so mobile radiography can be used in surgery. We usually use our fluoro unit or our C-arm. That's what we use in the surgery setting. Usually, we help with a lot of different types of surgery cases: neurovascular, orthopedic. We also do have portable x-ray machines in the surgery suite as well. But when we go to the surgery suite, they want to keep it very clean and sterile. So there are some rules that everyone that goes into the surgery suite has to follow. So they don't let everybody in. So access is limited to those who are supposed to be there and those who have a legitimate reason to be there. When you go in the surgery setting, you have to have special surgical attire. And then the equipment that we have in the surgery suite must be wiped down with appropriate aseptic solutions. And if we're using the C-arm or the X-ray, the portable machine, in a sterile setting, we have to make sure we cover our items that are gonna go in the sterile field, not to contaminate the sterile field, and in order to get our imaging completed. So some hospitals do have imaging equipment reserved only for use in surgery. And they do it like this to reduce contamination. Sometimes they do, sometimes they don't. But for the most part, you usually have your surgery equipment and it'll kind of live up there because when they call you, they're gonna need you. So you don't have time to continuously take a C-arm up and down the elevator to get it in surgery. So a lot of times you have a dedicated or maybe a couple dedicated C-arms in the surgery area. They're stored there, and then you may have a couple different portable x-ray machines in that area as well. So when we go into the surgery setting, we go into a surgery case, there are different members in the surgical area or on the surgical team. You have two different types of members. You have sterile members and you have non-sterile members. So your sterile members are going to be your surgeon, your PA, your physician's assistant, a non-physician's assistant, a scrub person or a scrub tech, which a scrub person can be a registered nurse, a LPN, or a surgical tech. So your non-surgical team are going to be your anesthesiologist or anesthetist, your circulating nurse or surgery tech, and then other technologists such as biomedical tech, orthopedic tech, and of course the radiologic technologists. So the difference is the people in the sterile field are going to be the ones that are working on the patient. They're going to be the ones that are kind of manning the sterile instrument table. They're the clean team members. And then your non-sterile clean members are going to be the ones outside of that sterile field. So we're not actively engaged in touching the patient or doing anything in the patient. We're anything to the patient. We're just waiting on standby if they need imaging to look at certain things while they're doing their surgery. So when we go into the surgery setting, that special attire that I was telling you about, we have to have a non-sterile shirt and pants. So that's usually going to be the scrubs that you have on. Then we need to have a mask that covers our nose and our mouth, a hat or a hood covering your hair, and if you have a beard, covering your beard as well. Shoe covers may be optional. I say put them on because they're there, they're free to you. We spend a lot of money on our shoes. And in the surgery case, you don't know what you're walking into or what'll happen. So using shoe covers just to protect your shoes, just a good idea, a good practice. And then also gloves. You want to keep some gloves handy, just in case you have to touch anything, just in case something falls on the floor, you need to pick it up. Just nice to have some gloves handy, just in case you need some. So when you go into the surgery setting, they'll have a surgical setup, a specific surgical setup. Part of that surgical setup is a sterile corridor. So this is the area between the patient drape and the instrument table. Only those wearing sterile attire are allowed in this area. So some guidelines is always be aware of your sterile field. Do not wear anything that dangles. So like not dangly earrings or anything like that. You want to avoid putting objects in your pocket that can fall out. And then you only want to pass behind the back of a sterile team member to avoid contamination. So your sterile field is going to be defined as a microorganism free area prepared for the use of sterile supplies and equipment. So some pointers in maintaining the sterile field: you never want to reach across the sterile field. If you suspect an item is contaminated, you need to discard it. You don't want to pass between the physician and the sterile field, so not in front of the physician in the sterile field, pass to the back of the physician. And then you never want to leave your sterile field unattended. So we're gonna watch a video that kind of gives us an idea of how to set up a sterile field. Now, keep in mind that when you work in different settings, you'll have people train you on how they like to have their sterile field set up. So this is just for demonstration purposes. You may learn a different way to do it when you get in the field. But I just want you guys to kind of have an idea of what it looks like and how to do it.
Well done, Viv. You got the presents, the balloons, and the raptor cake.
Hi, I'm Betty Hall from Chesapeake Urology, and I'm going to be demonstrating a sterile field setup. Before setting up a sterile field, make sure that you are in a closed room and that there's no other patient traffic. Next, you're going to disinfect all the surfaces that you're going to be using. Keeping the outer edge. And now that all surfaces are disinfected, you're going to wash your hands. You want to make sure to wash your hands thoroughly in between your fingers, your wrist, and down to your elbow. And then you're going to rinse thoroughly. And then dry thoroughly. You're going to dry from your fingertips down to your elbow. Now that my hands are clean, I'm going to start to set up the sterile field. I'm going to take the first sterile field drape. This is a non-fenestrated drape, meaning it doesn't have a hole in the middle. I'm going to open the drape and pick up the corner. Just let it drop. Then I'm going to inspect my package to make sure that there's no punctures and also that the indicator has changed. That will tell me my instruments are sterile. I'm going to very carefully open my pack, being careful not to touch the sterile field. Drop the instruments. Most sterile fields will also call for some sterile gauze. I'm going to pull the top off, drop it on the field. Just going to finish opening my supplies here. So at this point, I'm going to open my gloves. These are sterile gloves. Before touching them, I'm going to go wash my hands thoroughly again. Okay, now I'm going to glove. I'm going to open my gloves, touching only the outside of the tabs. I'm going to put my right glove on because I'm right-handed. So I'm going to have one sterile hand and one non-sterile hand. With my non-sterile hand, I'm going to draw up the local. This is lidocaine. This has not been used. If this bottle had been used and did not have an expiration sticker on it, it needed to be discarded. Whenever you open a bottle of local, you need to date it that day and put an expiration date on it. Just going to take my lid and let my lid drop. This is my syringe and needle. I'm going to drop the cover off the needle, bring back some air into the syringe, and draw up the lidocaine. Okay, being careful not to get any liquids on your tray. Now I'm going to put my other sterile glove on. Now I'm going to arrange my tray. Okay, just some points to remember. This sterile field is always waist high. Never brush up against it or reach over it. If you accidentally do any of these things, you need to start the whole process over because you've contaminated your field. This concludes the demonstration of a sterile field setup.
Thinking to start cutting cars.
Okay. So, like I said, that's just a demonstration. Once you get out in the field, you'll be trained on how to set it up because different doctors like stuff set up different ways. So if you work in a procedural area where you do procedures, you may, you'll probably have training and they'll show you how to set everything up. All right. So we're going to move from a sterile field to sterilization. So those instruments that they use in surgery, how do they get them cleaned? They use them on different patients. Some of those things, some of the things that they use are one-time use items. But a lot of those metal tools or metal items that they use in surgery, they use them multiple times. So they have to have a way to clean or sanitize and kill the germs on those items. And one way they do that is by a process called sterilization. So medical asepsis is a method of reducing pathogenic microorganisms in the environment and intervening in the process by which microorganisms are spread. Surgical asepsis is the process of creating and maintaining an area that is completely free of pathogens. And sterilization is the complete destruction of all organisms and spores from equipment used to perform patient care or procedures. So there are several different types of sterilization. You have chemical sterilization, autoclaving, conventional gas sterilization, gas plasma technology, and dry heat. Autoclaving is going to be your most commonly used type of sterilization. So an autoclave is a device that provides steam sterilization under pressure and is the quickest and most convenient means for items that can withstand heat and moisture. So we're going to watch a quick video about autoclaving and how it works, just giving you a kind of demonstration, an idea of that specific process.
On a gauge, or some units will have timely and keep. Director of Clinical Education for Crosstex International. Today, we're going to talk about the use of sterilization. In particular, in dentistry, steam sterilization is the most popular because it is the most efficient and the most effective. So let's talk about some of the parameters that are important for steam sterilization. In using a steam sterilizer, you're going to be looking for time, temperature, and steam under pressure, which will be indicated either on the LED readout, on a gauge, or some units will have a printout. It's important to understand how the steam sterilization works so that we can make sure we're doing best practices when using this form of sterilization. The way that steam is generated in an autoclave is that water will fill into the chamber. You always want to make sure with your particular autoclave to refer to the gauges that you know that you have adequate amount of water to create steam. The energy is transferred when the saturated steam touches the metal instrument, which causes a condensation and it's immediate transfer of heat. And it's that heat that kills the microorganisms on the instruments.
There are a number of features that you want to check to make sure that your sterilizer is operating appropriately. The first thing you want to look at is your fill station to make sure that you have adequate amount of water in the sterilizer. Another important part to look at on your autoclave, not just every once in a while, but at least once a week, you want to take a look inside the door at the gasket that surrounds the chamber. Does that rubber gasket look dry? Do you see cracks on it? Is there some sort of a film on the outside of that gasket that should be wiped off that's going to allow for a better seal so that the appropriate pressure can build up inside the autoclave? When the seal is in place, it allows the pressure in the gravity displacement autoclave to build up. Because the steam is lighter than air, the steam enters from the side of the chamber as well as from the top of the chamber. As the steam enters, it pushes the air from the top of the chamber out through the bottom of the valve because you want to have that entire chamber filled with saturated steam. Another important thing to check is that you're using the appropriate accessories that come with your sterilizer. You're using the appropriate trays or vertical racks for stacking so that you can make sure that the instruments are being placed inside the sterilizer as appropriately as possible. When the sterilizer finishes, it's important that you make sure that you have a record of the steam parameters that were met, that being time, temperature, and steam. It should be recorded in writing or else with a written document that's produced by the sterilizer. Did it reach the appropriate temperature, which is 121 degrees Celsius or 250 degrees Fahrenheit? You'd also want to record if it reached the appropriate pressure. That pressure is going to be between 15 and 18 psi or pounds per square inch. And the last thing that you want to record is the time. Depending upon the temperature cycle that's used, the time will be anywhere from 15 to 30 minutes. Those are your physical monitors that are going to be important for you to record. So in case you need to refer back to a specific cycle or a day that was run, you'll have those records available to you.
All right. So even though that was kind of steam sterilization or autoclaving in a different setting, it just demonstrates how it's done. So how the machine works, how they actually sterilize the equipment. All right. So sterility indicator. So how do we know once those instruments have been cleaned, gone through the process, how do we know that they're sterile? So there are sterility indicators that are used. So usually these items are put into some type of packaging. They're gone through, they're ran through this machine, and then they have identifiers on the outside of that packaging to let us know that the items are sterile. So usually there's some type of tape or seal that is one color before we start, and then when the items in the bag have reached, or the items in the container have reached sterility, the tape changes colors. So that's one way for us to tell that the items have been truly and have gone through the sterile process and cleaned appropriately. So that's pretty much all I have for you guys tonight. Here is your study guide. Couple things before we wrap up tonight. This is our last live lecture of the term. So next week is the very final week of the term. So I want you guys to applaud yourself because you got through this term. Give yourselves a pat on the back. But kind of just want to give you some information about next week so you know. So next week, which is week 8, the last week of the term, the week or the term ends on Friday. So you need to plan to have your work turned in by Friday. So when week opens Wednesday, like you normally do, you need to have your initial discussion posted. So that's Wednesday. Everything else should be turned in by Friday. So your 2 responses to your peers should be turned in by Friday. And then your test, your final exam should be turned in or completed by Friday. Any missing week 7 coursework needs to be turned in by Friday. Now, I know on the discussion, it says, it has like a general kind of description. It says, first initial post Wednesday, follow up is Sunday. But I'm telling you guys right here, right now, that follow up should be turned in Friday for week 8. Your final exam should be completed by Friday, on or before Friday. Now, the reason why they have us, or we make sure we want you guys to kind of finish out the term Friday, is because we have to get your grades prepared. And we usually have to have your grades turned in on Saturday. I know it may have on the due date, it should have a day that it's due, and a day that is open till. So it'll be open until Sunday. It's due on Friday. Don't let those dates confuse you. I'm letting everybody know it's due on Friday. If for some reason you have any extenuating circumstances that keep you from completing your final on Friday, please email me and let me know. Because I'm gonna have to answer to that if your grades are not complete. So I have to give a report of who has not taken their final. So if you, for whatever reason, extenuating circumstances come up, you can't complete it Friday, please let me know. Now, Sunday is the absolute last day. Term closes Friday. Assignments are still gonna be open Saturday and Sunday. Now, after Sunday, the class is gonna be closed. I can't do anything with it. If you need to do something, I have to reach out to the program director. He has to get somebody at the school to open the course back up. After Sunday, there's nothing I can do. So once again, if you have extenuating circumstances that are going to keep you from doing your work or completing your work by the due date, which is Friday, please reach out and let me know. All right, is everybody clear on that? Everybody understand? Okay. If you guys have any questions, you can put them in the chat or you can email me afterwards. If not, then you can go ahead, type your name in the chat box for outgoing attendance, and you all have a good rest of your night. Thanks, everybody.